Welcome to the deep dive. Today we're jumping right into one of the toughest challenges in oncology, small cell lung cancer, specifically the extensive stage SCLC.
Yeah, it's a particularly nasty one.
It really is. It accounts for, what, 13 to 15% of all lung cancers? And the really stark thing is for almost 40 years, the 5-year survival rate was stuck below 7%. Just grim.
Absolutely grim. And the first-line treatment, it basically didn't evolve in all that time.
Right. Patients were facing this incredibly aggressive cancer with a median overall survival of only like 9 to 11 months. It just highlights how badly change was needed.
As a clinician back then, those conversations were incredibly difficult. Progress felt, well, almost non-existent for SCLC compared to other areas.
That must have been so frustrating. But then things did start to shift, didn't they? Around 2019.
Yes, exactly. We saw the approval of new immunotherapies. Finally, a bit of hope.
And that brings us to today's deep dive. Our mission is to really unpack the findings from an interesting Italian study, the CeLEBrATE trial.
Right, a multi-center phase 2 trial.
Yeah, and they looked at adding a fourth drug, Bevacizumab, to that newer standard combo of carboplatin, etoposide, and Atezolizumab for SCLC.
So a 4-drug regimen. Quite intensive.
Exactly. We want to see what this approach offers. Efficacy, safety, and how it stacks up against what came before in this fight.
Okay, let's set the scene properly.
So for those long decades, the standard was platinum the cisplatin or carboplatin plus etoposide.
That was the backbone.
And it did get responses, right? Objective response rates of 50, 70%.
It did, yeah. Which sounds pretty good on the surface, but the huge problem was how long those responses lasted.
Ah, right. Not very long.
Unfortunately, no. Most patients would progress pretty quickly within just a few months, and that brings you right back to that grim median survival of 9 to 11 months.
So the responses were short-lived.
Very short-lived, and no other chemo strategies really managed to beat that benchmark for decades.
Okay. And then came the immunotherapy revolution. You mentioned 2019, these PD-L1 inhibitors like Atezolizumab and Durvalumab, they really changed things.
They did, significantly. They work in a pretty fascinating way.
Oh, so?
Well, essentially, they take the brakes off the immune system. They restore the T cell's ability to recognize and attack tumor cells.
Okay.
And SCLC, which is often linked very strongly to smoking.
Right.
It tends to have a high mutational burden, lots of genetic errors, and also genomic instability.
Meaning the cancer's genetics are chaotic.
Exactly, kind of scrambled. And theoretically, all those errors, all that chaos, creates more flags, more targets for the immune system to potentially see.
Ah, I see. So the ICIs help the immune system actually act on those flags.
Precisely. It gives the immune system a better chance to find and fight the cancer cells.
And this wasn't just theory, right? We saw this play out in big trials, like Empower 133 and CaseBN.
We did. Those are pivotal. Empower 133 added Atezolizumab to chemo.
And what did that show?
It showed an improvement in median overall survival, 12.3 months versus 10.3 months with chemo alone. And progression-free survival also improved a bit, 5.2 months versus 4.3.
Okay, so a couple of months improvement in the median. And CaseBN.
CaseBN used Durvalumab plus chemo. Similar story there. Median overall survival was 12.9 months versus 10.5 months with chemo alone.
So again, about a 2.5 month gain in the median survival. Which, I mean, it's progress, but maybe doesn't sound world-changing.
Well, that's the interesting part. If you only look at the median, you miss the really crucial finding.
Oh, what's that?
It's what happened further out. The longer-term data from these trials showed something quite remarkable.
Okay.
The addition of the ICIs roughly tripled the number of patients alive at 3 years compared to chemotherapy alone.
Tripled. Wow.
Yeah. It's what we call the tail of the survival curve. You plot the survival graph, and instead of dropping right down towards 0 after the median, the curve with the immunotherapy flattens out higher up. It means a meaningful subset of patients, maybe not the majority, but a real group, were getting a much longer-lasting benefit. Years, not just months.
So it wasn't just shifting the average slightly, it was giving a significant minority a much better long-term outlook.
Exactly. That was the real game changer. It fundamentally changed the potential future for some people with SCLC.
Okay, that makes sense. Now, the CeLEBrATE study we're focusing on didn't just use chemo and immunotherapy. It added this other angle, angiogenesis inhibition.
Right. Using bevacizumab.
And angiogenesis, that's the formation of new blood vessels, right? A hallmark of cancer.
Absolutely. Cancers need a blood supply to grow and spread, and SCLCs is particularly aggressive in this way. It relies heavily on creating new blood vessels.
And we know that this VEGF, vascular endothelial growth factor, is a key driver.
It is. High levels of VEGF are linked to a worse prognosis in SCLC, so targeting it makes biological sense.
Which is what bevacizumab does. It's an antibody against VEGF-A. Stops those blood vessels from growing.
Correct. It inhibits that pathway.
But, as you hinted, this wasn't the first time bevacizumab was tried in SCLC, was it?
No, it wasn't entirely new. There were previous trials, like SALUTE, and another called Pharm6-PMFJM. They combined bevacizumab with standard chemotherapy.
And what happened in those?
They did show some improvement in progression-free survival, delaying the time until the cancer grew back by maybe a month or two.
Right.
The PFS was around 5.5 to 6.7 months.
Okay, so some benefit there.
But crucially, they showed no improvement in overall survival. The median OS stayed stuck around that 9.4 to 9.8 month mark. Same as chemo alone, basically.
So if it didn't improve survival before, why bring it back now and add it to the chemo plus immunotherapy? What was the thinking behind this 4-drug combo in CeLEBrATE, this synergy hypothesis?
That's the key question. And the answer lies mainly in preclinical work in lab models.
Okay, what did those show?
They showed that combining VEGF inhibition, that's bevacizumab, with PD-L1 inhibition, the immunotherapy, had synergistic anti-tumor activity in SCLC models. They seemed to work better together than either one alone.
Synergy. How? What's the proposed mechanism?
Well, the theory is quite elegant, actually. It seems that the VEGF pathway doesn't just build blood vessels, it can also create an immunosuppressive environment around the tumor.
Like it protects the tumor from the immune system.
Sort of, yeah. It might prevent T cells from getting into the tumor effectively. So by blocking VEGF with bevacizumab, you might be breaking down that protective barrier.
Letting the T cells in.
Exactly. Making it easier for the T cells, which are already being unleashed by the immunotherapy, to infiltrate the tumor and do their job.
Ah, okay, so but potentially primes the tumor for the ICI.
That's the hypothesis. Plus, the chemotherapy itself causes tumor cells to die and release antigens.
Right, more flags for the immune system.
Which could further stimulate the immune response. So you've got potentially 3 mechanisms working together.
Okay, that makes sense biologically. So let's dig into the CeLEBrATE study itself. You said Italian, multi-center, phase 2, single arm.
Correct. Single arm means no direct comparator group within the study. Its main goal was to see if this 4-drug regimen showed enough promise, a signal of activity, to warrant further testing, maybe in a larger phase 3 trial.
And the regimen was specific doses of carboplatin, etoposide, bevacizumab, and atezolizumab.
Yes. Given together every 3 weeks for 4 to 6 cycles as induction therapy.
Okay.
And then patients who responded or had stable disease continued with maintenance therapy using just the bevacizumab and atezolizumab.
Got it. And the patients. Who was enrolled?
They enrolled 53 patients. Median age was 65, about 45% women. All had extensive stage SCLC, confirmed measurable disease, and importantly, a good performance status, ECOG 0 or 1. They had to be relatively fit.
Any unusual criteria?
One interesting point was that patients with asymptomatic brain metastases were allowed in.
Oh, that is interesting. Often they're excluded, aren't they?
They often are. So this potentially made the study population a bit more representative of, real-world patients you might see in clinic.
Okay. And there were some things specifically not allowed during the treatment.
Yes, important points. Prophylactic cranial irradiation, PCI, wasn't permitted during the study treatment.
Yeah.
Neither was consolidation radiation to the chest.
Right.
And this is a really critical detail for later. Primary prophylaxis with GCSF, the growth factor to boost white blood cells, that was also not permitted by the protocol.
Not permitted. Why was that? Isn't neutropenia a known risk?
It is. The decision, according to the paper, was based on an expectation of a low rate of febrile neutropenia with this regimen. As we'll see, that assumption had significant consequences.
Okay, let's park that for safety. First, the main results. Did it work? Did it meet the primary goal, the 1-year overall survival rate?
Yes, it did meet its primary endpoint, technically. The 1-year OS rate came in at 61.8%.
Oh.
And statistically, that was significantly better than the predefined null hypothesis, which was set at less than 50%.
But you said technically. Was there a catch?
Well, the researchers had actually hypothesized they'd see a 70% 1-year OS rate. So while it met the statistical goal against the lower bar, it didn't quite reach their more ambitious target.
I see. Still, 61.8% sounds pretty decent compared to historical numbers. What about other efficacy measures? Median survival?
The median overall survival was 12.9 months.
12.9 months. And progression-free survival?
Median PFS was 6.2 months.
Okay. And responses? How many patients saw their tumors shrink?
The objective response rate was high, actually, 83.3%. Out of 48 patients who could be assessed, 40 had at least a partial response. No complete responses, though, all partial.
Wow, 83% ORR is quite impressive. So the regimen is definitely active. It shrinks tumors in most people.
It certainly seems active, yes.
But activity often comes at a cost. Let's talk about that safety profile now, especially with that GCSF restriction looming. How tolerable was this four-drug combination?
Yeah, this is where things get more challenging. The safety profile was, well, substantial. Grade 3 or 4 adverse events, the serious ones occurred in 64.2% of patients. So nearly two-thirds experienced severe side effects.
That's quite high. What were the main issues?
The most common severe event was neutropenia, low white blood cells. Grade 3 or 4 neutropenia hit 52.8% of patients, over half.
Wow. And that's without routine GCSF.
Exactly. Other significant grade 3-4 events included hyponatremia, low sodium in 11.3%, arterial hypertension, high blood pressure, likely from Bev, in 5.7%, and thromboembolism, blood clots, also 5.7%.
Oh, absolutely. Dose reductions were needed in 45.3% of patients, almost half. And dose delays were even more common, 73.6% during the induction phase and nearly 70% during maintenance.
So frequent interruptions and dose adjustments were necessary to manage toxicity. That definitely impacts the practicality.
It does. It shows the regimen is difficult to deliver exactly as planned for many patients. And then there's the most concerning safety aspect you alluded to earlier, the fatal events.
Yes, unfortunately, this is the really sobering part. 4 patients, which is 7.5% of the total enrolled, died due to treatment-related adverse events.
7.5%. That seems high. What happened?
2 patients died from septic shock during febrile neutropenia, that's severe infection when white counts are low. 1 died from pancytopenia, where all blood cell counts drop, and 1 from pancreatitis.
That rate, 7.5%, how does it compare to the immunotherapy trials like Empower 133 or Caspian?
It's definitely higher. Those trials reported treatment-related death rates more in the range of, say, 3.0% to 4.5%.
So roughly double the rate of fatal toxicity in CeLEBrATE.
Approximately, yes. And the study authors themselves connect this directly to the protocol decision about GCSF.
They acknowledge the lack of primary GCSF prophylaxis likely contributed to those neutropenic deaths.
They did state that in the paper. It strongly suggests that if this regimen were to be used, mandatory primary GCSF support would be absolutely critical.
Okay, so let's try to put it all together. We have an active regimen, high response rate, median OS of 12.9 months, but significant toxicity, frequent dose modifications, and a higher rate of fatal side effects. How do you view these CeLEBrATE findings in the broader context?
Well, what's really striking is when you put that 12.9 months median OS right next to the pivotal trials that established the 3 drug regimens.
Empower 133 and Caspian.
Exactly. Empower 133 had a median OS of 12.3 months. Caspian was 12.9 months.
The same. Add in Bevacizumab didn't actually improve the median overall survival compared to just chemo plus immunotherapy.
Based on these numbers, no. Despite the biological rationale, despite the high response rate, the median survival benefit wasn't pushed further by adding the 4th drug in this trial.
That's a really critical takeaway. But what about the tail of the curve? You mentioned CeLEBrATE had a decent one-year OS rate, 61.8%. Could this 4-drug combo still be offering that longer-term benefit for a subset, even if the median isn't better?
That's the million-dollar question, isn't it? It's possible. The one-year OS rate being numerically a bit higher than historical controls, and maybe even slightly higher than seen in the control arms of the phase 3 trials, hints that perhaps this combination could benefit some patients longer term.
So similar to the ICI effect itself, maybe not moving the middle much, but helping a few more people live longer.
It's a possibility suggested by the one-year OS data, yes. But we have to be cautious.
Why cautious? Beyond the toxicity, I mean.
Well, mainly because CeLEBrATE was a single-arm phase 2 study. It gives us a signal, but it's not definitive proof because there's no internal control group for a direct comparison.
Right. It shows the drug is active, but doesn't prove it's better than the alternative on its own.
Precisely. And this is where a crucial external context comes in from another trial.
Oh, which one?
There's a randomized phase 3 trial called BEAT-SC, run it in China and Japan. It tested a very similar combination, chemo, Atezolizumab plus or minus Bevacizumab, so a direct comparison.
Okay, a head-to-head phase 3. What did BEAT-SC find?
Well, the recent interim results are quite revealing. BEAT-SC did show an improvement in median progression-free survival with Bevacizumab 5.7 months versus 4.4 months, so it delayed progression.
Similar to the older Bev chemo trials then. But what about overall survival? That's the key endpoint.
Exactly. And the third interim analysis for OS and BEAT-SC failed to show a benefit from adding bevacizumab. The median OS was actually numerically worse in the Bev arm, 14.1 months versus 16.0 months in the chemoimmunotherapy arm.
Wow. So the larger randomized trial, directly comparing the 3-drug versus 4-drug regimen, found no OS benefit and maybe even a detriment.
That's what the interim analysis suggests, yes. Now, it's interim, things could change, but it certainly pours some cold water on the idea that adding bevacizumab definitively improves survival over the established ICI chemo standard.
That really puts the CeLEBrATE results into perspective. It highlights the importance of randomized data.
Absolutely. Phase 2 signals are important, they generate hypotheses, but Phase 3 trials are needed for confirmation.
So it seems we're left with a combination that's definitely active, as CeLEBrATE showed.
Feasible and active, yes, those are the words used.
But it comes with significantly higher toxicity,
Yeah.
including fatal events, especially without careful management, like GCSF.
Correct.
And based on CeLEBrATE's median OS and the BEAT-SC results, it doesn't seem to clearly improve survival over just adding immunotherapy to chemotherapy.
That appears to be the situation, yes. It underscores the critical need for balancing efficacy and safety. You need careful patient selection and very proactive management of side effects if you were ever to consider such an intensive regimen. The GCSF lesson from CeLEBrATE is paramount.
Okay, so wrapping up this deep dive. The CeLEBrATE study gave us valuable initial data, a proof of concept for this 4-drug approach in first-line SCLC.
It did. It showed it's possible to combine these agents and that they have activity.
But the take-home message seems to be that despite that activity, the median survival wasn't better than the established 3-drug ICI regimens, and the toxicity was considerably higher.
Yes, and the larger randomized BEAT-SC trial further questions the overall survival benefit of adding bevacizumab in this setting. Still, CeLEBrATE adds to our understanding, exploring that synergy hypothesis, even if it didn't quite pan out in terms of a major survival leap.
Right. Which leaves us with a final thought for you, the listener. Extensive stage SCLC remains incredibly challenging. The prognosis is still poor for many. Even if a complex toxic regimen like this doesn't improve the average outcome, could there still be value if it offers that slim chance of longer-term survival, that tail-of-the-curve benefit, for just a small subset of patients?
That's the difficult question researchers and clinicians always grapple with.
How do we balance chasing those potentially meaningful long-term gains for a few against the risk of increased toxicity for the many? And what kind of breakthroughs, perhaps different combinations or biomarkers, will it take to finally lift survival prospects for all patients facing this aggressive disease? Something to ponder.